But we're going to go into our example patient here and how we start from the beginning to the end here. So this is our 14-year-old with no major past medical history. She's missed her friends during the pandemic, is not sleeping well. She's gained 15 pounds in the last 6 months, and now she's just embarrassed to see her friends. She used to be an A student. Her grades are now C's and D's because she just can't get into Zoom school. She used to play soccer, but now she doesn't feel like getting out of bed or being active. She did have somebody in her family who was hospitalized with COVID-19, and this actually began to cause a lot of her worries. She was worried about her parents dying from COVID. She can't get these thoughts out of her mind. She denies suicidal intent. And a couple of months ago, she started seeing a therapist. She thinks that it's helpful, but it's not enough.
In pre-visit planning with this patient, it's touching base with your care manager, or again, it might be a particular individual who becomes your touch point within the office, because they will hopefully have the most contact with this patient over the preceding few days to weeks before they presented, and just kind of get the lowdown of what's going on. Surveys, when our patients call and are concerned and are coming in with the concerns about depression or anxiety, our care manager sends them surveys electronically through our portal to fill out and return, and so to review those in advance. And then again, seeking those records from anyone. This patient in our example has seen a therapist. Can we get a consent form in order to speak with their therapist and learn a little bit more, see if there's other things that we should be looking at, the possibility that maybe there's some background trauma or drug and alcohol use. Do we want to be sending out other surveys to look at other information on this child, just other than our standard PHQ-9 and GAD-7s?
During the visit, you want to review the results of the screens. Your template is going to focus your visit, but I start with an open-ended discussion. And sometimes what I'll do is review the results of the screens, ask what's happening. Can you give me some details? What are some of the things I need to know about why you're feeling the way you're feeling? Usually that first visit will be in person, and I'll want to do a physical exam, and it's sometimes in follow-up we'll want to do that as well too, particularly if you are looking at weight loss or weight gain, if you're looking for cutting, if you're looking for any sorts of things on physical exam that might suggest that there may be a substance abuse component to this, and that follow-up can be via telehealth. So our patient is admitting to feeling sad. She doesn't want to do the things that used to make her happy. She doesn't want to see her friends. And this is, again, despite 2 months of working with a therapist. So a question about, do I refer as the ASQ as ask? I mean, it's you can call it either one of them. I always confuse the ASQ with the ages and stages questionnaire. So I usually will just call it ask because we're asking. Our patient doesn't have suicidal intent. We have diagnosed her with depression, and we're considering starting medication. And so depending on how well you know your patient and family and how much data you have gotten and what you've been able to get from discussions with your care manager or with her therapist, you might consider starting an SSRI. You would want to discuss benefits and side effects. You might want to think about following up via telehealth in 1 week. Generally with SSRIs, I will follow up in 1 week to look for side effects. That's my big thing. And at the same time, I won't start medication unless I've already had somebody actively in therapy, because I want somebody else touch pointing this patient. You want to follow up in 2 to 4 weeks to be able to assess good effects. And with most SSRIs, the literature will tell you that you will likely not see a good effect until 3 to 4 weeks out. Sometimes you'll see it earlier than that. And then to recommend at least weekly visits with the therapist where they've already got an established relationship. This is going to be talking a little bit about medical decision-making and how you get the margin to meet your mission here. When you look at the new codes for the new 99204, 99214 for medical decision-making, and you're looking at moderate problems, what you'll see in here is that these visits at least are 99214s or 204s and are moderate problems. So you have one chronic with exacerbation or progression. You have somebody who's depressed, they're seeing a therapist, they're not getting better. You already meet that there. or a one diagnosed new with uncertain prognosis. That again is germane to anxiety or depression in practice. When you look at moderate data, you have to meet at least one of three categories. So category one is ordering any unique tests, review of prior external record, review of unique tests. What about labs with some of these kids? I will very often do a CBC, a TSH, maybe a comprehensive metabolic panel, especially in a kid like this one who's gained a lot of weight in the last several months. So that would meet category one. Category two is independent interpretation of tests performed by another provider. And then category three is discussion of management with an appropriate source. So if you have reached out to and discussed or gotten information through your care manager from a therapist, you would meet category three. And then moderate risk, when we talk about medication and indications for medication, and particularly if you start it, you meet that moderate risk clearly. Diagnosis or treatment significantly limited by social determinants of health. I include insurance with this. So if you've got somebody who's got insurance and the only psychiatrists around you accept cash, that's a social determinant of health problem. If you work in a federally qualified health center and you don't have access, or kids with Medicaid and you don't have access to psychiatry, or the wait list is 9 months long, that's a social determinant of health factor. So these all play into that moderate MDM decision making. I would tell you, by and large, most of my visits with kids who have anxiety or depression meet the criteria for high or a 99215. So your high problems, again, that one or more chronic with severe exacerbation, progression, or side effects of treatment. You're going to be talking about this, whether it's that initial visit where that child is seeing the therapist and isn't doing better, or that child is not doing well. If you think about it, the data in the literature is showing us that in the last year, anywhere between 9 and 10% of adolescents have had a suicide attempt, which is horrifying. But that is a really important place to put this as a high problem. When you look at your high data, again, ordering your unique tests, interpretation of those tests. And then category three is important because that's the discussion of management with an appropriate source. So you want to look at who your historians are. It is often going to be the adolescent, but it's often going to be the parents as well too. And then thinking about an independent interpretation and discussion with an external provider on care management, which could be the therapist. And then your high risk, again, is going to be looking at your intensive drug therapy and talking about medications, good effects, side effects, what's happening with your particular patient. So if you think about the amount or the complexity of the data to be reviewed, when you look at your 99214 in moderate, it meets one of these three categories. But in your 99215 is going to meet two out of these three categories. So if you're reviewing screens, you're reviewing messages from a therapist, you're talking with your care manager about what's going on with this particular patient. If you are discussing management, if you're talking about medication, you will very likely make these visits a 99215. They will meet that high medical decision making. So our 14-year-old, the patient and parent are historians. Mom's a historian. You've reviewed your screens. You've reviewed your notes from your therapist. You've discussed and started medication with risk benefit and a follow-up plan discussed. That meets the extensive 99215. So you can code for these because of the medical decision-making complexity. The nice thing about the 2021 codes, again, too, is that medical decision complexity comes without having to do a physical exam. So that's what helps to make this by telehealth something that you can do and make your margin to meet your mission.